Hello and welcome to the EMJ podcast with me, your host, Dr. Jonathan Sackier. Today, I'm joined by Professor David Baldwin, a leading expert in respiratory medicine with a focus on lung cancer, for the second episode of a lung cancer mini-series. Dr. Baldwin is a consultant respiratory physician at Nottingham University Hospitals, the National Health Service, NHS Trust, and an honorary professor at the University of Nottingham. He serves as lead clinician for lung cancer at NHS England, chair of the United Kingdom Clinical Expert Group for Lung Cancer and Mesothelioma, and advisor to the UK National Screening Committee. Dr. Baldwin's been central to developing the National Optimal Lung Cancer Pathway and the Targeted Lung Health Check Programme. With over 240 publications and tens of millions in research funding, his work focuses on lung cancer CT screening, epidemiology, and health service delivery. And he's played a key role in the United Kingdom CT lung cancer screening trial. Outside of work, and it's astonishing to think that he has any time, Dr. Baldwin's a dedicated teacher, family man, and an advanced windsurfing instructor. Um, there's a lot to unpack here. Welcome to the podcast, Professor David Baldwin. Real pleasure to have you here.
Thank you. Delighted to be here.
So before we get into the serious stuff, please tell us about windsurfing. I've actually tried the sport. I love to sail, right? I love to sail boats. So I thought, yeah, how difficult can this be? Goodness gracious me, it is difficult. So tell us about how you got into it and such like.
Well, I would question whether it's difficult. I think it's all about, who you've got teaching you, what the conditions are like, what the equipment is like. People all too often think, oh, it's a nice windy day, especially sailors. I'll have a go, and then you realise that it's a very different thing to actually sailing a sailboat. Although interestingly, we find that the sailors who've got at least some wind awareness are generally better at that aspect of things. But having a bit of balance and having some nice, relatively calm conditions, you don't need to get too wet. You always get wet though; it's part of the fun. And the more advanced stuff is just very exciting, and it's a real outlet for me, both doing it myself and also teaching people at our local sailing club. So it's really nice, and I just don't get to do enough of it still. And as I get older and older, it's more difficult to pick up where I left off and improve, unfortunately. But hey, it's all about getting a bit older.
I have the sense that I was just hanging on for dear life. And the whole thing about when you sail a boat and you're just in that sweet spot at the right point, 45, 50 degrees off the wind, and you can just
Yeah.
feel the power in the sail, but you don't have to hang on to the boom. Which is something. So anyway, let's get into the meat of this. You've been closely involved in some of the biggest trials around CT screening for lung cancer, the UKLS, for instance. What do you see as the most important takeaways from this, and specifically the impact on reducing lung cancer mortality? And then maybe you can also address where we are in terms of difficulty in getting funding. You and I were chatting about this, and you were saying that lung cancer doesn't get. Actually, let's start with that. Lung cancer doesn't get the same amount of funding, or there's lack of appeal to lung cancer. Tell us about that.
Yeah, I mean, the statistics are astonishing about the lack of funding historically and ongoing in lung cancer research. If you calculate the amount of money that's spent per death from cancer and compare it, say, to breast cancer, then there's a 40-fold difference in the amount of funding in breast cancer screening compared to lung cancer screening, for example. I'm not saying we should spend less on breast cancer. We just need to acknowledge that we need to spend more on lung cancer. And I think that narrative has helped. There has definitely been an increase in the amount of money that's become available. But having worked in this area of research and led a committee called the Screening Prevention Early Diagnosis Committee for the then NCRI, it was very obvious to me just how much more money was available for the other tumor sites compared to lung, despite lung cancer being the cancer that kills more people than breast and colorectal put together each year. And you can almost add prostate onto that, and you're nearly at the figure that lung cancer, just over the figure that lung cancer has. But nevertheless, we are making progress, huge amount of progress in lung cancer. I think that the screening trials, again, that UKLS screening trial was an example of lack of funding in that we ran this small pilot, and during the setup of that small pilot, the big American trial published and showed that there was a 20% reduction in lung cancer specific mortality, and not shown in any other tumor site screening trials previously. There was an all-cause mortality reduction as well of 6.7%, sort of unheard of, reflecting the high number of deaths that you get from lung cancer, then influencing the total mortality. So this was, it first published, we were a bit skeptical about it because we thought, well, being a scientist, we'll scrutinize this. My journey through this was to be very skeptical initially, and then realize that the way the trial had been designed was such that it could have shown an even better mortality benefit had it actually screened the correct people and run in the correct way. And what they did do is design it to prove essentially whether or not lung cancer screening worked, with an eye on actually disproving it rather than proving it. And actually, they had to stop the study 1 year early because it reached its stop criteria 1 year early. And then while we were doing the UKLS study, which was initially in a pilot phase, what we found was that the early stage detection rate was better, statistically significantly better than that discovered in the National Lung Cancer Screening Trial. So we demonstrated with modern CT scanners and modern techniques, using a lot of the techniques borrowed from the Nelson trial in Europe, that we could do it even better and get better early stage detection rates. And I'm happy to see actually that has translated into our national program. We are still getting better early detection rates than they did in the original National Lung Cancer Screening Trial in the US, and they are now doing in their own program. So we do it rather well here. We've got lots to learn, and it's thanks to the huge dedication of people in the service, that and the belief that this will work, that we've managed to get this screening program off the ground. But I'm sad to say that when we went back to the funders for the full trial, which would have given us an ability to show a mortality difference in the UK, the funding was refused, as there wasn't sufficient funding. And that was, at the time, we were asking for about 20 million. And that is not a big amount of money for a screening trial of the sort of size that we were planning. So again, it was all about the sort of prejudice against lung cancer, I think, that we didn't get that money. It was a difficult time at the time with research funding, but nevertheless, it always is, I think.
Yeah.
And that's the history of it. But it's a phenomenal trial, and the long-term follow-up shows just how much the mortality from the screened people is separating from the people who weren't screened. Partly, I think, due to other aspects of the way the National Health Service runs, in that once you've had a screen and you've had a scan, you're in the system. The system seems to worry about you, and you get a lot of other added benefits, which we're also seeing now in our screening programs. So, really positive about that trial. It really did lead the way onto pilots that then showed similar findings, and finally the big national pilot, which was a bit of a shock when they approved it in NHS England well before the UK NSC approved it. It's been a funny journey.
I would have thought, I mean, you mentioned that being denied funding, that this is one area, in my area, in colorectal, you can demonstrate that if you pick up polyps and you remove them before they become cancers, the
Mm.
impact, never mind mortality and morbidity, but for the bean counters, without sounding too pejorative, it's very easy to show a huge cost saving. I'm surprised that that would be a barrier. And secondly, you've mentioned that the prejudice against lung cancer. Why? Is it because it's self-imposed?
I think that is the assumption, is that this is it's not nicotine addiction which has been imposed upon people as a result of failures in the way we've educated and run the societal measures to reduce that aspect. And we're still doing it with vaping, in a sense, aren't we, with the nicotine addiction? And the prejudice is, it's amazing how it continues, and it's not just the the medical staff, the public, it's the patients as well. They apologize for having developed lung cancer quite commonly. It's really awful, but we are getting through that a bit. I've seen a recent campaign about not being prejudicial against people that develop diabetes on the TV recently. We haven't seen very many not being prejudicial about people who develop lung cancer. I don't think I've ever seen that. So
Hmm.
it's interesting, isn't it? Even that
Yeah,
level of prejudice applies to this self-inflicted, as they call it,
words
disease. So
words
yeah, it is
matter.
all about that, I think.
Yeah, words matter. I mean, the narrative around lung cancer has been, especially over here, these gory pictures on cigarette packets, and
Mm,
the advertisements have always been, I didn't know that I was doing this to my body, and then you're talking through a trach or whatever it might
mm,
be. So yeah, words matter,
mm,
and if you
mm.
don't have the communication message correct, then there are consequences to that, and I
Yeah,
guess you live
yeah.
that. So you've been involved in various research projects like the Four in the Lung Run trial. Can you address the issue of recruitment and maybe overcoming the barrier we've mentioned and any other barriers, and tell us a bit more about that project?
Yeah, thanks. That's a very important aspect, as you've seen from my sort of research on this. And I think there are a couple of things to mention. Firstly, when we were looking through how to optimize a screening program, there were lots and lots of different things that we needed to optimize. Most of which we had evidence for and we could fix. And a lot of my talks at the time were about showing what was possible and what we needed to do and how we could do it. But the thing that was always a real worry was this concept of participation rate. We knew that we were going to be finding difficulties because of the demographic. Lung cancer is twice as common in the uh, quintile of the most deprived socioeconomic status compared to the top quintile. So you've got this unfavorable sociodemographic of people that are traditionally um, not offered or able to engage with health prevention measures and screening. So we were struggling there, and I was always really worried about the participation rates. So a lot of the studies that we've been doing have been about around participation. There have been a number of really good studies done in London. The lung screen uptake trial, for example, used all of the techniques that we knew to work in other screening programs, such as primary care and physician invitation, repeated reminders for the appointments, scheduled appointments, repeat schedules appointments, all of these sort of things, and they found a pretty good uptake rate of about 50% of a lung health check, and then that translated into a lesser number of people that actually had the CT scan. And then we've been really interested in novel methods used by industry to try and engage with people through media that they normally uh, engage with and respond to. And the big businesses are quite good at this because they want to know how to get people into their supermarkets and their shops, etc. So they've got a lot of data on what works with different sectors of society. And a company called Experian, I've not no financial conflict with Experian, um, have this process sectorization of the population where they can tell almost by street what type of media people will better responders to. And we were trying to do this within the European setting where unlike the UK, where we know from the primary care data where people are, a lot of about the population and how we can target them. In Europe, they don't have that, so they need ways in which they can target their invitation materials to the different populations. And using this sectorization, which is available in Europe as well, you can say, well, this area here has a fairly high chance of responding to written invitation materials with relatively low burden text. Whereas this area here would be much better by getting them online, for example, because they're more likely to respond to that. And that's what they're doing essentially in the Four in the Lung Run study. They are doing these various different forms of recruitment methods and showing some pretty interesting results. They're not published yet, so I can't really share them, but they are actually quite interesting and somewhat surprising. So it does seem to be working in Europe. We haven't managed to test it there's bespoke methods that we're developing in the UK for this, but I think actually it already seems to be working. So the study is moving on quite rapidly. It's doing a number of other things. The Four in the London study, looking at when the next screen should happen, how frequently the next screen should be compared to the baseline risk of lung cancer. And our program in the UK is already a stratified program as well, in the sense that we know from two of the big studies that if you've got findings on your initial CT, you're more likely to develop lung cancer in the next year. So we do more frequent screening in that group and less frequent screening in the group that don't have findings. And that's a sort of stratified as well as targeted program. So we're already doing that well ahead in the UK in terms of our program compared to some of the other countries. And the Four in the Long Run study should add some detail to that and some extra evidence. So I'm looking forward to that result.
Really interesting your comment about using the Experian expertise. The concept of thinking outside the box in medicine. I mean, I fly aeroplanes as an avocation, and many of the safety protocols that we've used in aviation for a long, long time have, of course, now made their way into surgery, checklists, and so on and so forth, crew resource management. And I think this willingness to think outside the box and say, okay, that you know, there's no such thing as the typical doctor. There's surely no such thing as the typical patient, and finding ways to communicate with people in less of a sort of a patronizing, paternalistic approach, rather engaging people. What's the great story about Willie Sutton, the American bank robber? And the judge said to him, "Why do you rob banks, Mr. Sutton?" And he said, "Well, Your Honor, that's where the money is." It's about going to where the money is, I guess. So the targeted lung health check program's been running for a while now. What have we learned so far from the data coming out of it, and how's it shaping where the program might go next? It was a focus of Lord Darcy's report, you pointed out. So tell us a bit more about that, please, David.
Yeah, so it's the Targeted Lung Health Check program started as a very large national pilot ahead of the UK National Screening Committee's recommendation on lung cancer screening. That recommendation we can discuss later, but it was a little slow in coming, and I think people were generally impatient because of the level of evidence that we had for lung cancer screening. So the national team at NHS England, having had some advice, were discussed initially in further small pilots, and then all of a sudden they decided that they would just go for the full program, and that was a bit of a shock to me because we were quite concerned about the capacity that we had to deliver this. But the targeted lung health check has been astonishing. It's been astonishing because of the way in which the national and local teams have managed to implement this, and the way they have learned from the first, second, and third wave pilots to do this really efficiently. And the net result, as Lord Darcy pointed out, was that it has changed the the profile of the stage distribution in lung cancer as a whole. Even though at the time of the data being reported, we were only at around about 25% of the people of the population coverage. And of those people that were covered, only about half of them actually responded to the invite, and only about half of those are actually eligible for a scan.
True.
So we've seen a dramatic climb in the stage 1 and 2 detection rate. And more importantly, we have seen that this increase has been greatest in the lowest socioeconomic quintile, such that that quintile, for which for all cancers has the lowest proportion of stage 1 and 2 lung cancer detected, has now moved over the course of the program to the top. So that's the first screening program I'm aware of that actually reduced inequalities, because most screening programs, because of this issue of participation, actually increase inequalities. So it's a big success story, and when we're talking about participation rates, we are seeing what I regard at the moment as unexplained um, differences in participation rate. A few times in Nottingham, where I work, we've had to actually run extra scanning days because we've had an unexpectedly high participation rate of over 70%. I mean, in Newcastle and Gateshead, they in one area they had a participation rate of 78%. which is way off the scale in terms particularly with this demographic. And we're not completely clear why this is. We don't have any scientific evidence. I do have my suspicions. And one of the things that I've noticed when talking to the people and seeing them sometimes present at meetings um, that run the programs, particularly the administrators, is the passion that they have for this program. And that passion, I think, is fueled by the fact that they are part of that community. And because lung cancer is quite common in the community, they will have experience, either a friend, a relative, will have had lung cancer. And that makes a really big difference when they can see what happens to them and what the potential is for, future the future of people when they've had the early stage detection. It fuels that passion, and it means that when they are recruiting and advertising the program to people and explaining to people, they're enthusiastic, and they also and there's a lot of trust there that comes with it, I think, for the potential participants. And I think that for me is probably the explanation. I haven't got any proof for this really, but it's seeing the passion. One of the things that I'd like to share with you is one presentation that was given at a UK Lung Cancer Coalition meeting, which we had on screening in London. And it was an administrator from one of the programs. And she put a slide up which just had a number on it, which was over 100. I think it was about 180, and just waited. And she said, "This is the number of people that have developed lung cancer who decided not to go into the screening program. And most of these people, unfortunately, now have died." For her, this failure, this missed opportunity, was one of the biggest things that she had thought of. This was somebody who'd bothered to go and check to see all of these people and what had happened to them. That just gives you an idea of the passion. And I think this is one of the things that will make the program a big success in the future. If we can make sure that everyone who may be eligible for this knows about it, know that it's a good thing, knows that it's benefits people on the basis of early detection of lung cancer, but also are working really hard to make sure that all of the incidental findings that are beneficial benefit the people, and all of those incidental findings that should be ignored are ignored, so that there's reassurance that we're doing our very best to get the maximum out of the program.
Yeah.
I think that will be the key to the ongoing success of the lung cancer screening program.
Yeah. Your observation about the impact of the socioeconomic status. I remember when I was working in Washington, D.C., which is a sort of a bivaricated city. You've got the uber wealthy on one side of the city and the outrageously poor on the other. And
mm,
of course, disease incidence is very different,
yeah,
and stage of disease presentation. We didn't see early breast cancers present from the poorer areas of DC. We saw them present when they had a fungating
mm,
mass
yeah,
that had broken through the skin. And
mm,
so, yeah, good on you for achieving that. It's fascinating. And hearing about one person who took the time to go and search for data and seeing the human impact, because very often, if we get tied up in the science, we lose contact with the humanity that
mm.
is the motivation to do this work. You've done a lot of work, David, using large data sets in lung cancer epidemiology. How do you make sense of the variations in care in outcomes across regions, and as we've talked about, socioeconomic groups? What have we learned from that kind of data at scale? And maybe you could link that to the National Optimal Lung Cancer Pathway, how it's worked across different regions, biggest hurdles, and getting it widely adopted. Floor is yours.
Yeah, so this is a work that I've done with colleagues in the University of Nottingham, and what we did was to take the National Lung Cancer Audit, which was a non-mandatory audit of lung cancer, and we were able from that data to show that the variation in outcomes, treatment, the access to treatment, the amount of surgery, amount of radiotherapy, amount of chemotherapy was highly variable across the country. But also because of our sort of logistic regression analyses, we could control for factors that would normally expect to influence that. And what we found is when you controlled for all of the sort of factors like age, performance status, and comorbidities, and these sort of things, there was still a marked variation. And it was related to the way the cancer service had been designed back in 2000 with the hub and spoke system, in that we found that the big hubs with surgical services on site, and for lung cancer, and sophisticated techniques, lots of expertise, were delivering much more treatment to their patients. And what's more, they were delivering much more treatment to their own patients as opposed to patients that were referred into them as well. So there was this issue of a disparity between the hubs and the spokes. Not all spokes and not all hubs, but that was the general trend. And it was quite marked. So the first data, for example, we showed that if you were first referred to a site that had thoracic surgeons on site with lung cancer, you were 52% more likely to get surgery for your lung cancer. And then we redid that 3 or 4 years later, and it was 38% more likely to get surgery for your lung cancer. No other explanation other than the fact that you were first referred to that. All the other things controlled for. So this was quite a concern. And one of the things that I've been thinking about, well, it's all very well having this research, but what can we do about it? And that's where I sort of interact between my research and my, a national role. And I felt I proposed this to the clinical expert group, has a fantastic group of 40 experts who really do know a huge amount about lung cancer, very enthusiastic. What should we do about this? And we talked about how we might change the commissioning of cancer services. So instead of saying, I'm working out in the sticks somewhere, I've only got one chest physician who's trying to do everything, including lung cancer, I can't get another chest physician because no one wants to work there. So instead, I'm going to commission that service for my hospital from another area where we do have a lot of people. In other words, a very radical change in the way we commission services, and getting this concept of of responsibility for the entire population within the cancer alliance structure, as opposed to all of these hospitals working in silos, which is what we have at the moment. And I put that proposal we'd gone through this commissioning guidance, including a stipulation for the minimum amount of time required, clinical time required, to deliver a lung cancer service for all the specialties. And it went to the Programme of Care Board, and they said, well, it's a great document, we'd like to see a whole pathway as well, please. And that's where the National Optimal Pathway came from. So we developed two pathways, the aspirational one and the optimal one, sent it round with the aid of CRUK and NHS England for a very wide stakeholder consultation, which was very useful because I created a spreadsheet which had all the comments. And when later people were asked to implement the pathway, and they said, oh, we didn't agree to this, I was able to send them their comments and say, well, actually, this is your comment on the Excel spreadsheet. This is what you said, which was really quite useful. And we ended up with the aspirational pathway being the optimal pathway. We got rid of the optimal pathway, and it was very tight time frames. It became, a national priority to my surprise, and it went from being something that was shunned, really, and in sort of some disbelief of being so aspirational, to something that was being implemented widely. It's still really difficult to implement, primarily because of capacity. The hospitals that are able to implement it just got a lot more capacity than the ones that haven't, and that's the problem. We need more capacity if we're going to do this properly. We need the people and the kit. And the National Optimal Pathway demands that we have that, because you can't achieve it unless you have the people and the kit. It's also been really useful when we have a problem with a part of the pathway, and this has really helped other tumor sites. So when we had a problem with national delivery of PET scanners, for example, where PET scanners were just not frequent enough, and spread out enough to actually give us a decent PET turnaround time, the National Optimal Pathway was saying, well, you need a PET scan within 5 days of you deciding that the person needs a PET scan, and preferably sooner, because it's at the beginning of the pathway. It determines all the downstream activity after that for accurate diagnosis and staging. And this led to a big initiative on provision of PET scanners. The PET scanners were massively increased. We had a lot of mobile scanners initially, and then fixed site scanners, a lot of use of the private sector because of the difficulty with getting these scanners in there, a lot more cyclotrons installed. So all of this fueled that. And whenever we do have a bit of a bottleneck, the pathways are really useful to say, look, this is a problem. So with the most recent one has been the genomics thing, very, very important for making sure people get the correct targeted treatment, but impossible turnaround times and never been really dealt with. So we really have focused very strongly on this 10 working day turnaround time to full genomics analysis in the national optimal pathway, and that's a 14-day turnaround time in calendar days. So that's what's been worked to now, and we are seeing improvements. So it's good to drive changes in service. And that's working. It is not at the moment working in all centres by any means because of lack of capacity, but having something there is really important. And the other benefit it's had for other tumour sites is now we have 10 pathways, 10 optimal time pathways produced by NHS England for other tumour sites. So they've all got these pathways that they're working towards to make sure that we're trying to at least improve our services. Without that nationally agreed pathway, you're stuck. And I'm glad to say Scotland have got their national optimal pathway. Wales have a pathway which is quite similar to the English one, and Northern Ireland have one which is difficult to implement, but they're working hard. And the only other area that I know of that have a national optimal pathway at the moment is Australia, where they have an optimal pathway, but it's only operational in one state. And there's a big global initiative at the moment going on about talking about optimal pathways, which has been centered around the fact that we've done this in England. So it's research to evidence, and evidence to some way of trying to get this working, and again asked for by people who asked for something fairly innocently and ended up with this thing that could be quite a heel for the national services, but actually I believe is quite useful. And it's
Mhm.
really interesting. I'll show you one slightly denting experience I had at one point where I was presenting this new pathway at the British Thoracic Oncology Group, which is a lot of enthusiastic people that meet together, big meeting, and the chair said, "Well, so who's trying to implement the national optimal pathway?" And about 5 people put their hand up. Oh no. But next year, he asked exactly the same question, and all the audience, pretty much all the audience, put their hand up. So that, that's testament to people's ability to take these things and run with them if they can.
Yeah, and how gratifying to actually see something, as you say, go from the hypothesis to the research to implementation. It's the true translational
Yeah,
work. So
and
we've
with
mentioned,
everybody's input as well. That's the other thing. I
yeah,
mean, I
yeah,
think so many people inputted into it and had their say. And yeah, really good.
frankly, that's the only way when you effect a field change, especially in medicine.
Yeah,
They say about my specialty that we're always certain, occasionally right. But if you're going to effect change in medicine, it has to be collaborative, or
yeah,
you have to bring people on a journey, or
yeah.
you end up going on a solo hike. So we've mentioned big data, the obvious extension, that's AI, hot topics. You're leading projects that are using them in lung cancer, one in chest x-rays in symptomatic people and the other in pulmonary nodules. Tell us about those two and maybe hint at other promising ways you think that these technologies, AI, big data, machine learning algorithms, how they can help.
Yeah. So I think I mean, we are embracing AI all the time in life in general and also in medicine. And a lot of the AI goes unnoticed because it's relatively low level machine learning. It's still using, you know, techniques that have been based on how the brain works. So
Mhm.
it is using especially effectively artificial intelligence, but not particularly high level. Um, but I'm really also quite concerned about how well the AI is being evaluated. So that's where I come in a sense. I've been really interested in making sure that things work and they don't have unintended consequences in medicine. And one of the reasons I got involved with this very large randomized controlled trial of artificial intelligence applied to chest X-rays was about wondering what the total impact of this would be. What are the useful aspects of it? What are the things that are actually could be quite damaging to the NHS, particularly generating a lot of extra work with no benefit, and also what might be the clinical benefits. And I've also been thinking very hard with colleagues about what type of study you should have to try to fix this problem of evaluation. Now, the lung impact study is answering a clinical question, and it's saying, if you have immediate triage as a result of the artificial intelligence flagging an abnormal chest X-ray. Does this make a difference in terms of time to the CT scan, which is the next test in the lung cancer pathway, and the time to lung cancer diagnosis? If it were to make a substantial difference to time to lung cancer diagnosis, because we know in lung cancer that is so important, it's so critical how quickly you make the diagnosis, then it would change NHS practice. This one study would change NHS practice because it's adequately powered and it's measuring an important clinical outcome, very important clinical outcome. If it changed time to CT, that would be encouraging, but it may not. People may not choose to say, well, this is standard of care now. And then there are other aspects. Does it pick up things that the radiologist missed? Is it picking up far too many things and making a lot of work? All of these sort of things are part of the secondary outcomes of the study. And it's a randomized control trial because it is measuring a clinical outcome. You don't need a randomized clinical trial just to check whether an AI is working or not. But you do need the clinical outcome, and that's why it's been funded for a fair amount of money, and it's also taken a long time to implement. And the lesson I've learned is how difficult it is to run these type of studies in the NHS with the available expertise, the concerns about privacy and all sorts of things, which shouldn't be a concern. And it's one of the things I need to do, is on my list to do, is to write a paper with colleagues on what needs to happen, what needs to change in the NHS to make this easier. What do we need to change? There's lots of really good guidance documents on what you should do, but not what actually needs to change. People on the ground that we need to do this more efficiently, because it's taken a lot more effort.
Do you mean
And
research in general or the specific?
well, in particularly AI research, it's not the same as that. People are good at running pharmaceutical trials, with a drug. They're used to that. They know exactly what to do. It's all set out. But with AI, you've got your IT department to deal with. You've got your data protection to deal with. There's so many different aspects of this that people are unsure about, and there needs to be a process by which that level of expertise is available, and it's not at the moment, unfortunately. That's the big problem. But as I say, that's a topic on its own. The trial is now finished recruiting. It recruited 100,000 people, and we have 5 sites that are recruited, and we're excitedly looking through the data at the moment to make sure that before it goes off the independent statistician, it is absolutely clean and that all the timings are correct. That's taking quite a long while, but it is absolutely essential. We absolutely have to make sure all this effort is not spoiled by a lack of detail at this stage. So I'm really driving that quite hard, and we expect to have results by November, which will tell us the primary outcomes and the secondary outcomes together. We've completed a massive number. The radiologists have been amazing, and the radiographers, they've completed a huge number of discordance reviews, over 40,000 discordance reviews. So whenever the AI disagrees with the radiologist, they have looked at those X-rays. That's astonishing, isn't it? And a wealth of data coming out of that. And of course, it's all been done to a high research standard, so it's not the same as just running something and looking at the results. And it's really tight. So that's very good. I'm looking forward to that. Then the other study that I'm involved in is about a much higher level AI. This is a program that has been developed to look at a pulmonary nodule on a CT scanner and estimate its risk of being lung cancer. And the idea here is to use a different study design, this time something called a shadow mode study, where you run your normal service and you run the AI alongside it. And you say, well, what would have happened had I been using the AI rather than following the normal service? So we run the normal pulmonary nodule algorithm and we run this AI next to it. And then we say an expert panel and look at the decision by the clinical team, the decision by the AI, and we say, do they agree or not? And if they don't agree, in which direction do they go? In the favouring malignancy more or favouring benignity more? And that's what we're looking at in that. And that's recruited about 700 people at the moment, and we're trying to get to 1,000 to do that. We should have enough power to see whether this algorithm in particular allows us to discharge more people from the pulmonary nodule service safely. So that's a shadow mode study. And then the other thing I'm working on with my colleague in this office here is to look at platforms which are validated platforms that can test and retest different versions of AI. And this has already been done quite extensively in many different products, notably skin cancer AI products, retinopathy products, and also here in breast mammography products. And it's really interesting what you find when you have one of these validated platforms, which is essentially a series of images in the same platform as you get on the NHS with ground truth attached to them. It's surprising, what happens with your apparently, according to the company, working algorithm. It's not always that good. And it could be again a game changer here, because you have 10 different products. The NHS tests them in this validated platform. One of them is brilliant, then that's the one that becomes the choice, because it's passed the test. Or you might say that you've got five, in which case you've got five to choose from. And that's pretty much where we're at with the different designs of the studies. And for me, it's been a new area. I've had to learn quite a lot of stuff that I didn't know before, and it's been really interesting, actually. And I think that the potential for AI in imaging in particular is huge. We just need to be really careful that we test the baseline products, we test the new versions, and we have a process by which we give a sort of kite mark or something to each of these, and they have to be tested, rather than just allow them to be upgraded willy-nilly in the service without any evidence that they might work. And any new technology that's introduced, we need to test them in that new technology. For example, recent thing is photon counting CT, for example, which is a great new technology. Not many hospitals have got these photon counted CTs yet, but they will have. They'll reduce the radiation dose a lot. But does the AI work with them? We don't know. We have theories that it might, but we haven't actually tested it. So those are the type of things that we need to be doing. We need to do this proactively.
Yeah, it makes my use of AI to help me design holidays.
Very
It
good.
seem quite dismissive. So you've helped shape some of the major lung cancer guidelines through the British National Institute of Health and Care Excellence, which they call NICE. I've always thought they should call it niche. It should be and health excellence. And the British Thoracic Society. What's the hardest part of turning emerging evidence into practical recommendations that clinicians can and will actually use? You've already touched on it, and we've talked about creating a collaborative environment where you bring people on a journey. But yeah, if you can address that, please.
Yeah, so I think so one of the things that I said to myself when I was chairing or doing the clinical lead of the 2011 NICE lung cancer guideline was that I realised that this was going to be a lot of work. And I thought to myself, well, at the end of this guideline, I'm going to make sure that I do my absolute best to implement it, because there's no point in spending 2 years of your life doing all this work and then no one even looks at it. And which was the sort of flavour we had from the 2005 guideline. Many of the cancer teams just didn't really know it; they'd not read it. And so I actually took a fellowship up with NICE. You can do these clinical fellow posts where they just tutor you for 3 years, and you have to have a project. And my project was implementation of the guideline. And I talked to a lot of really good academics on implementation science. I actually explored the whole area of implementation science, so I learned quite a lot about what determines behavior change, how you might do the right things to ensure that people will actually use these guidelines. And the principles really are that people have to have the opportunity to do something. In other words, and that means the access and in a guideline, they need to be able to see it. They need to be able to be aware of it. It has to be the opportunity to at least do it. And then you have to have the capability. In other words, they need to be able to understand it and implement it. And then the motivation to do it as well. So you've got these three things are underpinned by a lot of other principles as well. But that's primarily what I did. And with both the National Optimal Pathway and the NICE guideline, I just did an awful lot of presentations, and also got an awful lot of other people to do lots of presentations once they were well equipped with what we were saying in the new guideline. And the motivation comes from having things that you've done in the guideline which are actually quite useful. So there are a lot of really good things in the 2011 guideline that set out, how you should be approaching this whole area of lung cancer. One of the key things was, one of the statements was, choose the investigation that gives you the most diagnostic and staging information with least harm to the patient. So this concept of just doing a bronchoscopy on someone because you can do a bronchoscopy, when in actual fact you need to know whether their mediastinal nodes are positive or their liver has got a metastasis in it. It had changed the way, it was hopefully changing the way people were thinking. That was just one of the principles. There's several other things in there, which gives people the motivation to say, oh, actually, this is really useful. I need to do this. I must do this. So I think part of it is about a lot of hard work, being prepared to go around, talk, get other people to talk, develop meetings, try and get a group of people who are the enthusiasts who then go out. We used quite a lot the networks there with the expert advisory groups to discuss the NICE guidelines. So we had a network in which we could explain all this sort of things. And then exactly the same principles applied to the British Thoracic Society guideline, but with one essential difference. One of the things was suggested, because we were using multivariable models, was that we should have an app to enable people to easily use these multivariable models, and which would also include the algorithms that appeared in the pulmonary nodule guidance. That was amazing. And interestingly, guess where the most downloads were from? The US. The US were using, they were just going against all of the sort of, what they would normally do. And they were using British apps to help them manage their nodules. And there was one famous paper where myself and Matt Callister, as the co-chair on the BTS pulmonary nodule guidance, we had this paper saying that actually physicians weren't following the nodule guidance from the US. They were actually not operating on high-risk nodules and operating on people that got low-risk nodules. And that's because they were doing PET scans and reclassifying the risk of the nodule, which is exactly what the BTS guidance was saying, and the US guidance at this time was saying not to do. So he wrote this letter back to them saying, well, actually, all they're doing is doing PET scans and reclassifying, which incidentally is what we recommended in 2015 in the BTS guidance. So it was a bit of an eye opener that this app had been so useful. It was just another method of delivery of your guideline.
Yeah.
In terms of saying, well, here's an app. People like apps. And what's the risk of this nodule being malignant? And sure enough, it's low risk. We'll just observe this. Or this is high risk. We'll do a PET scan. It's even a high risk. We'll take it out. That's the type of
Yeah.
things that we do.
And I'm again, there's a recurring theme, because you talked about, well, there's this whole thing about how do you implement something. Well, there's this thing called implementation science. I'm going to
Yeah.
go and learn about that. And again, I commend you for your intellectual humility, because very often as doctors we think, well, we're doctors, we know, but lo and behold, there's all these other folks with special expertise that we can learn from across domains. So I want to go a little bit off piste as we near the end of the conversation, David. I know this isn't specifically your area of specialty, but you know more about it than I do, that's for sure. So there's been a number of social initiatives to address the root cause of lung cancer: bans on smoking in pubs, uh, jazz clubs, enclosed spaces, moves to get rid of tobacco altogether. Are we doing enough to explore the risks of vaping? I personally abhor walking along the street and getting a waft of somebody's strawberry smoke or vapor. I don't want that in my lungs, thank you. And the data on cannabis use are, to my mind, hard to dissect. Variable consumption, variable strengths. Often users also use cigarettes and so on. Again, I know this isn't your area of focus, but can you share some thoughts?
Yeah. So, I mean, firstly, I think we could do a lot more in to target situations when people are more likely to quit smoking. So for people who are established smokers, we know that if you have an event like a heart attack, for example, they're much more likely to quit smoking there. So focusing on people that have had an event of some sort. And the big event that we have at the moment that we've talked about already is the lung cancer screening setting. We know that from the studies that have been done in Leeds, and were led from Nottingham here, actually, one of my colleagues, Rachel Murray, has led the YES study, the Yorkshire Enhanced Stop Smoking study. They've shown a 31% 1 year confirmed quit rate if you are offered an opt-out interview with a smoking cessation advisor on the mobile van with follow-up and pharmacotherapy, which includes vapes, actually,
Hmm.
electronic cigarettes anyway. So that that is amazing, because that's way above the quit rate we'd normally expect. It's partly about the people that turned up. They're health conscious. They've said yes to a screen.
Yeah.
They're more amenable, and when we see them in the clinic, the screen people, they're often amenable to the concept of stopping smoking, which is really good. So that's number one. And then, of course, the other thing is to try to prevent people from getting addicted to nicotine, and this is where the issue of vaping is a problem. There's no doubt vaping is a good way of nicotine delivery, and that's why it's also a good way of getting people off cigarettes, because it's something they can do instead, and it's giving them a decent nicotine hit, similar or not quite as good as I understand it, to cigarettes, but still pretty good. The downs and the evidence is that smoking is far more harmful than vaping. The evidence that we have at the moment, anything that's been described about electronic cigarettes is usually at least tenfold worse in cigarettes. So we do have this issue of evidence being there, but not complete enough to say what is the long-term aspects of damage. Because the real issue for me is the fact that it's an unregulated industry. The additives that are additive are not under any limitation by being a drug. It's it's essentially classified as some sort of food product or something. They can put things into these products that have only a limited amount of evidence that they're not harmful. So we don't know what's going to happen in the long term. The intention was also always that you would use vapes to come off cigarettes and then get off your vapes. But again, it's about this motivation issue. Unless we can say to people that now you're off the cigarettes, that's great, but these vapes are likely to be harmful, you should come off those. Where's the motivation for people to come off this? So I think we have a real problem here. I mean, we are going to have legislation on vapes shortly, which should help things to a certain extent. It should, contract the manufacturing and the offer of this. But it is a problem. It's one of those dilemmas where, do you recommend vapes to get people off very harmful cigarettes, or do you focus on other effective methods, or not? The other thing that I don't know the answer to, but some of the tobacco industry are funding the vapes. You've got the very people that have sold cigarettes to people and are continuing to sell cigarettes to people in other countries less developed, knowing full well how harmful they are, who are now, manufacturing vapes. So
Yeah.
I think it's a real problem. I'm not an expert in this. I have listened, to a lot of people in different countries. For example, if you go to Australia, most of the people in Australia are dead against what we're doing in the UK with recommending vapes to come off cigarettes.
Yeah.
Absolutely against it.
Right. Right.
Really polarized the community. Whereas the lung cancer community in terms of screening is pretty much undivided, largely. The smoking is very, very different. I'm
Yeah.
quite glad I'm not an expert in this, because I don't have to get involved in all these arguments. But
A lot less cut and dried, yeah. So, finally, a question like to ask people: if you had 3 wishes from a genie for your area of healthcare, what might your wishes be? Just as we wrap up.
well, first of all, full implementation, a realistic one, full implementation of the lung cancer screening program, with proper advertisement, publicizing this as a really good health intervention, integrated with the most effective methods that we know of smoking cessation, would be my first wish. And I think that's absolutely achievable. It's just that people need to do it. Um, then the second wish would be that we have a proper um, approach to addressing the medical workforce for the NHS in general, specifically in areas that I'm interested in, which is lung cancer, of course. But you can't really just address lung cancer, the people for lung cancer, without addressing everything else. So it's a proper workforce plan to beef up the NHS to make sure that you can really deliver what the sort of standards that we all aspire to. And then a more specific one, which I think is very difficult, but I would probably change the commissioning structure for the way we ensure that people across the whole of our patches get the same service. And that would mean a lot of travelling for some doctors to the sites from centres. But if there are enough of us, then it wouldn't be that frequent. and a change to the attitude whereby, people like me sitting in our ivory tower of, excellence, etc., would be responsible for the people that are actually first referred in more distant areas. We would feel a responsibility. We have to deal with those as well. It's not just our own patients, and we're just doing tertiary services.
Yeah.
That's what I would do. They're the primarily the three things. One's
Very,
a big general thing, obviously. The other one is something that would change commissioning massively, which I think is unlikely. The first one is absolutely achievable. Could be done straight away, pretty much,
yeah.
if we put
Well,
our
I think if
mind to it.
anyone's likely to drive those wishes to completion, it's you. I'm afraid that's all we've got time for, but I'd like to thank you, Professor David Baldwin, for being with us today. A real pleasure to chat with you. I've certainly learned a lot, and I wish you continued success. And we'll maybe have you back when those studies read out towards the end of the year. That would be fantastic. Appreciate that.
Great pleasure. Thank you very much for inviting me. Thanks.
You're welcome. So, to the folks listening, if you're not a subscriber, subscribe. It's easy and it's free. And write a review and tell your colleagues and all that good stuff. And check out the archives. There's lots of great episodes on there. Please join us next week for another fascinating episode. Until then, I'm Dr. Jonathan Sackier. Thank you for listening to this EMJ podcast. Until we meet again, please stay safe, stay well, stay curious. Bye for now.